Just for clarification, Ermie and I work in labor and delivery, and Sonja works on mother-baby. So we're going to start with a reflection, which is a tribute to OB nurses. There's a special beauty witnessed in the making of a star. It's a secret that's kept solely in God's crystal jar. It's a jar that angels care for, daily polished from afar, for they know the worth imprinted on the cover of this jar. Let me tell you how they know this. Every day they look upon all the OB floors in motion, all the daily goings on. And within their hearts they marvel at the love and care bestowed by the nurses that they follow on this OB floor abode. There's no need to know the secret God's kept held within this jar, for the words upon its cover tell the meaning of these stars. It's a meaning of endearment, one that's held in high respect, and it speaks of all the beauty every OB nurse reflects. In God's foresight, he did see this. On a scroll he wrote with care. All the words known as a secret, stored them all with holy care. On the cover, an inscription that reflected their great work. All OB nurses are gifted. They are God's own handiwork. And we truly all feel like it's a great privilege to care for our patients. So postpartum hemorrhage, technically, is losing a lot of blood. We'll get to the exact definition in a minute. But postpartum hemorrhage is an obstetric emergency. It occurs in 4 to 6% of all deliveries. The increased blood supply to the term uterus allows for the loss of up to 500 cc's of blood per minute. So you can see that even a normal, healthy woman can become decompensated very quickly. Postpartum hemorrhage is the #1 cause of maternal death worldwide, resulting in 140,000 deaths per year. AWON, which is the Association of Women's Health Obstetric and Neonatal Nurses, they've started a new postpartum hemorrhage project, which is dedicated to reducing the number of women who bleed to death during pregnancy and birth. And according to the studies that they've done, up to 93% of maternal hemorrhage-related deaths could have been prevented. It can occur early, as in the first 24 hours, or it can occur late, after 24 hours. If a woman is left unattended and she starts to hemorrhage, she can bleed out and die in 2 hours' time. The normal plasma volume of a pregnant woman increases by 30 to 50% by term. So we have all that extra blood because we're kind of designed to lose it at birth, but because of that also we can lose a lot quickly. So our objectives today, we'll be able to define postpartum hemorrhage for a vaginal and C-section delivery and recognize signs and symptoms of excessive blood loss. We'll be able to identify the causes of uterine atony and the appropriate treatment choices. And we're going to talk about the drug therapy for postpartum hemorrhage, and we're also going to present a case of a patient that we had. So technically the definition is for a vaginal delivery greater than 500 cc's of blood loss, and for a C-section greater than 1,000 cc's. But really any excessive blood loss that makes the patient symptomatic can be considered a postpartum hemorrhage. There are 4 types of causes. They all start with a T: tone, tissue, trauma, and thrombin, and we'll go through each of those one at a time. Tone refers to the uterus. Uterine atony is when the uterus is completely relaxed. The uterus has to be firm and contracted in order to keep the woman from bleeding. Some of the things that cause uterine atony would be an overdistended uterus, a woman who's had polyhydramnios, which is too much amniotic fluid, or if she's got more than one baby, or if she's got a baby that's really big, which is macrosomia. If the woman has had chorioamnionitis or any other intra-amniotic infection and had a fever, if the uterine muscle is exhausted, either from a very quick labor or from a very prolonged labor, one of the things that we have to look for on a regular basis, mainly because we have one doctor who likes to use Pitocin for a long period of time. She's of the theory that she wants to give the patient every chance to deliver vaginally. And when we use Pitocin to induce them, and they've been on Pitocin for a really long time, they are more apt to bleed postpartum because the uterus is oversaturated. The Pitocin the receptor sites are oversaturated and it can no longer accept new Pitocin. One of the other things that can cause uterine atony is a woman who's had multiple births. The woman who is a gravida 10, para 9, we watch them very closely for uterine atony. Also, if there are functional or anatomical distortions of the uterus, if the woman has fibroids, or if there are other uterine anomalies, a bifurcated uterus, for example, or if she has a previa, which we'll talk about in the tissue one. This is a picture of what the doctor might do in the delivery room if the uterus is not contracting. It's called bimanual massage of the uterus. It looks painful, because it is. We hope that when we're doing this, our patients have had an epidural and they're not aware of this. But this is an excellent way that the physician can actually get the uterus to contract by massaging it aggressively. This is a balloon that we can use. It's called an Ebb tamponade balloon. I have one I'll pass around later. It's a balloon on the end of a catheter. It's got two balloons. Well, the first balloon goes up into the uterus, and we fill it with LR or normal saline and completely fill it so that it completely fills the uterus and tamponades all of the vessels in the uterus. It can stay in up to 12 hours, and we can also track how much blood is being lost from a tube that comes off of it as well. The bottom balloon actually can blow up in the vagina if the physician wants to tamponade anything there. If maybe the cervix is bleeding, that will help with that too. The second T is retained tissue. When we talk about this, we're talking about anything that's left in the uterus. If there are a lot of clots inside the uterus, when we massage the uterus after delivery, if there are clots in there, we have to express them and push them out, because anything that fills the uterine cavity will keep the uterus from contracting. And the uterus has to contract in order to keep the woman from bleeding. When we talk about retained products, retained placenta, I'm sure everybody's heard that term. If the placenta doesn't come out for a couple reasons, if the woman has had a previous C-section and she has had a successful vaginal birth after that C-section, sometimes the placenta will implant along the scar of the uterus, and it will become an accreta, and that placenta will not come out. So there are the only way to get the placenta out is to take the uterus out. Accreta, it just goes past the decidual layer right into the beginning of the myometrium. The increta actually goes further into the muscle of the uterus. And the percreta, it will actually grow through the uterus into the abdominal cavity and attach to other organs. So the only way to get that out is by hysterectomy. It's not always known ahead of time that the patient has that. It can be detected on ultrasound, but you have to have a really good ultrasonographer, and you have to really be looking for it in order to know that it's there. If they have a previa and they've had a previous C-section, their chances are really high of having an accreta as well, because the placenta, we know, is implanted down near the previous C-section scar, so that they are oftentimes an accreta. If you don't know that it's there and you deliver the baby and the placenta just does not come, if you can get the placenta out, if it's a focal accreta and it's just a small spot that's attached to the uterus, depending on how big it is, you might be able to contain the bleeding. But if it's the whole placenta, if it's a complete accreta, then the uterus will have to come out, because the only way to keep the uterus from bleeding is to remove it. So we end up doing a hysterectomy. And here's a picture of the accreta, increta, and percreta, and just how far into the uterus the placenta will go. The third T is trauma. And when we talk about trauma, we're really talking about lacerations. If we've had a precipitous delivery, or perhaps an operative delivery where the doctor has put on a vacuum or forceps, there's a chance that they might lacerate the cervix or the vagina. Hematoma will often develop in the vagina after the delivery, and the danger with that one is that you can't see the blood coming out because it just builds up behind the wall of the vagina, and the patients will complain of feeling a lot of pressure down there. They're like, I know I've delivered, but I still have that feeling of pressure. That always needs to be investigated, because it very well might be a hematoma and it will need to be evacuated. Another trauma would be uterine rupture, which is devastating, and it requires an emergent C-section. And depending on how much of the uterus has ruptured, the physician can often repair where it has ruptured. Sometimes it's so bad that the baby is actually in the abdominal cavity when they open the person to do the C-section. And depending, like I said, depending on how bad the uterus is lacerated, they can repair it and oftentimes save it. But they are cautioned about having another pregnancy. Uterine inversion occurs when, if the physician puts too much traction on the umbilical cord when the placenta has not delivered, it will cause the uterus to actually turn inside out. It will actually come out of the vagina inside out. And they can also have lacerations and extensions at a C-section if the baby is in a malposition, or if they've been pushing for a while and the baby is deeply engaged into the pelvis and they have to reach really far into the pelvis to get the baby's head out, they can lacerate the cervix. And this is a picture of what the physician will do to correct the inverted uterus. And it looks painful because it is. The fourth T is, we refer to thrombin, which is the coagulation problems that a woman might have. Hopefully we know about those ahead of time if they have a pre-existing condition such as hemophilia or von Willebrand's disease. But there are also conditions that can be acquired during the pregnancy, idiopathic thrombocytopenia purpura, ITP, or if they have had preeclampsia and develop HELP, which is hemolysis, elevated liver enzymes, and low platelets. So if they've had low platelets, they will bleed. And if they bleed too much, they can go into DIC. That DIC can also be caused by having an intrauterine fetal demise, or a severe infection, an abruption, or an amniotic fluid embolism. The way we treat this, if we actively manage the third stage of labor. All of our patients get a full liter of 20 units of Pitocin in 1,000 after delivery. At our discretion, we can hang a second bag if we feel like they're still bleeding. The most important thing that we do is fundal massage. It can contract the uterus and keep it from bleeding. If that does not work, then we move up the chain, as it would, and start giving drugs. Oxytocin, like I've said, is the first drug of choice. Most of our patients already have it running if they've been in induction and it's running in the IV. The onset is immediate and it can last up to an hour. If a woman comes in and delivers quickly and we don't have time to start an IV, or she's a patient that had a desire not to have an IV during labor, we can give it IM. Cytotec is another drug that works relatively quickly. However, it's one of those drugs that we give that's not FDA approved for what we give it for, but it does contract the uterus, and we give it rectally. We give 800 to 1,000 micrograms rectally. Methergin we give IM. Most of the doctors like to give this because it's quick and easy. We just have to be cautious with the patients who are hypertensive when we give it because it will cause the blood pressures to go up. The onset is relatively quickly, and it can last a couple hours. Hemobates last on the list. It's 250 micrograms. We give it IM. We like to leave that one for last because one of the big side effects is diarrhea. Patients don't like that. Nurses don't like that. If you are trying to quantify how much blood the patient has lost, and I know that when you call a physician and you're trying to explain how much blood, and everybody has their own idea of how much is too much or how much that's not really all that much. So the most effective method is by weighing. And you can put all of your pads up on a scale. 1 cc of blood weighs 1 gram. So if you are attending a patient who has been bleeding for an hour and you feel like this is just way too much, you can weigh them to get an idea how much blood has lost. If it's 500 cc's, 500 grams, you can call the physician and tell them exactly how much blood has come out. And that way it's not a guessing game. And they're not thinking, is she really bleeding that much? So if you give them an exact number, they can't argue with that. This is just a picture of estimations of how much blood is how much blood. All our pads, we have a chart available to us that has all our pads and what they weigh dry, but just kind of a visual of how much blood is how much blood. I like the last one, the 2,000 cc one, where it's actually running off the bed onto the floor. I don't know if anyone would wait that long before they call anybody, but that's what that looks like. Also, if you want to be more of a visual person, when you've called the doctor and you've said, for the last 15, 20 minutes, she's been bleeding a lot, I need you to come. If you just want to line up the pads on the floor in the room so that when they walk in, they're like, wow, yeah, that's a lot of blood. So the IHI actually has a bundle that tells us who does what during a hemorrhage. Hopefully we have 4 people that are on the unit when we have a hemorrhage. Don't always. But the first responder is the person who calls for help, starts massaging the fundus, and then evaluates whether the patient needs to empty her bladder. A lot of times a full bladder will keep the uterus from contracting. So that's kind of first line, make sure her bladder's empty. The second person who comes in response to her call will be checking vital signs, checking the O2 sat, putting O2 on the patient if they feel like that's necessary. If she doesn't already have an IV, we're starting an IV or perhaps starting a second line so that if we need blood later, we can do that, or if we're going to push fluids, we have the extra IV access. And then the fourth person is going to bring us meds. In our Pyxis, in labor and delivery and on mother-baby, we have what we call a postpartum hemorrhage kit. And it's a little plastic box that has those 4 drugs in it so that we can bring it to the room. We can give whichever one the physician has ordered, and if we need to give more than one, we have it all available to us right there in the room.